Breast sensation is a topic I personally cannot talk enough about. Patients want to be protected from burns, beauty products like curling irons. They want to feel the hugs from their family, their friends, their partners, their grandchildren, their children. To be honest, the feeling of numbness that many feel after mastectomy just feels odd. I speak from experience, and I listen to other survivors who tell me this. It felt odd for me, but I was fortunate to have nerve reconstruction after my mastectomy, and now I have sensate breast. I feel so fortunate today to be speaking to a world leader in breast sensation, and you will learn so much from her. I first met her at the London Breast Meeting in September of 2023, and this is one of the leading breast meetings in the world, and her talk absolutely mesmerized me. I saw her again in January of this year of 2024 at the microsurgery meeting, and we chatted for a few minutes and said, we have to get this podcast done. So I'm very, very humbled to have her on the podcast today because of her schedule, her clinics, the surgery she performs, and mostly how well thought of she is in the world of microsurgery. But I also want you to know how approachable, warm, and accessible she has been in arranging this interview. So I want to introduce you to Dr. Stefania Tuinder, and she performs complex microsurgical breast reconstruction at the Maastricht in the Netherlands. She's also published a number of papers on this topic. And I'm speaking to her today, fresh off holiday. So, Dr. Tuinder, thank you for finally. I'm so glad we were able to arrange this. It's just so lovely to see you and to speak with you.
Thank you to you, Terry. It's an honor for me to be here with you, and I think it's a very important thing, and I really wanted to make time for this. And actually, the honor is really, really mine.
Oh, thank you. Well, I have to tell you, I was a little bit inspired to talk about, we're going to talk about breast sensation today, but we're also going to talk about that mind-body connection. And I have to tell you, a mutual friend of ours, Vimal Gokani, who I listened to the deep cuts, the PRS Global Open Deep Cuts, which I'll put in the show notes. I just think listeners are going to want to hear that interview. He's such a lovely man, another microsurgeon over in the UK that we both know. But when he talked to me about this, Dr. Tuinder, I thought, I have to take a deeper dive into this topic. So I want to thank Vimal for kind of inspiring me to speak to you more about this. So I'll be sure and put that also in the show notes so that people can listen to it. But that was a great interview.
Yeah, sure. Vimal visited us, and it was immediately a good connection.
Yeah, yeah.
Sometimes with people, you have immediately a good feeling or not. Speaking about sensibility, and with you was exactly the same. So I'm very happy, and I really think that it's fantastic the work you are doing, because it's so important for patients to have knowledge about what's happening and what can happen and what can we restore. So again, thank you so much. I really want to spend the time saying that.
Oh, thanks.
About the sensibility, I think that it's even for everyone a concept where you are not thinking enough about it till you experience that indeed.
Boy, that's the truth.
Because it's so logic, it seems so like natural, we feel a lot, and there is a big discussion about what is sensibility and what is sensitivity and what is sensate, but we all know in consciously, unconsciously, we know what we mean, isn't it? But actually, if you think the concept of sensibility is a very, very complex concept, because it's not only touch, as you already mentioned. There are a lot of stimuli, and those are received from our body and then are elaborated from our brain cortex, the somatosensory cortex. And a lot of stimuli can play a role in that, like vibration, touch, cold, warm, pain. There are all informations that every day from every part of our body are coming up. And some of this information are elaborated locally, so they come not up, but most of them are coming up. And I want to mention a study of Professor Atzmann from Vienna. He's a worldwide well-known plastic surgeon, the leading one in bionic implants. So he's very focused on sensibility and proprioception for other reasons. And he published articles showing that in the big nerves of our body, the 70% sometimes of fibers are sensible. So we are an organ made to receive informations. That's the most important part of our nerves. And then with this information, we do like little responses, which is incredible. So we are just a sensible organ, receiving. And I think this is very important to understand how sensibility important is. And I think that for too much time is just forgotten how also the sensibility in a breast can be important. And I think that when we speak about sensibility of a breast, there are, at least at the end in all this year where I had the time to think about that and to actually speak with patients, there are two important factors.
Okay.
One is the erogenous sensation, which is something typical of a breast and only for the breast. It's not usually for every part of the body. But we did a little qualitative study, and so it means that we interview healthy people. And what we could find is that erogenous sensation, for example, it's not important for everyone. So I think I can see immediately when I have in front of me a patient where erogenous sensation in the nipple areola complex is important. Because in these patients, it's very clear to me that, for example, for a unilateral reconstruction, they are saying, oh, can I preserve my nipple and nipple areola complex? And, oh, I don't want that you touch my healthy breast, because if I will have scars there, something will change also at that side. And that's terrible, you receive hormones, you have a change in a lot of things. And this is very specific. So I know that when a patient is asking me, for example, to not to touch the healthy breast, or how important is to preserve the nipple areola complex in the breast with cancer, I have really to think even more to sensibility, and I have to think to the erogenous sensations. And in this patient, it's also very important. For example, we did a lot of study trying to give back the sensibility, of course, of a reconstructive breast. But when we are speaking about unilateral cases in these specific patients, I think it's really, really important to try to do our best not to touch the healthy breast, because there is the feeling perfect. So besides everything, sometimes you do other flaps, you do stacked flaps or whatever, just to leave untouched the healthy breast.
Mhm.
And I think there was an evolution even in this at this point also for my own career, because you start and you think, oh, I want to make a breast and I want to make in my head the most good looking breast I can do.
Mhm.
But sometimes it's not the most important thing, because sometimes sensibility can be so important that, for example, in unilateral reconstruction, you have to do whatever you need to make the same shape and the same volume and the same whatever on the mastectomy side, just not to have to touch the healthy breast. So I think it's a point we have really to discuss with our patients. And
Yeah, I'm thinking of something here as you're saying this, Dr. Twinder, because I don't know if this trends in Europe or other countries, but in the US, women who have a unilateral breast cancer, they often wonder if they should be taking both out. It's more of a peace of mind, worrying about if it will come back in the other breast. And maybe you can speak to that statistically, because this is something that I think is very important to know. If they don't have to touch that healthy breast, then, as you said, that will leave the natural sensation there. So maybe you can speak to the statistics of that, but also help us understand why a consideration of leaving the healthy breast is important, if I'm making sense. Because I almost feel sometimes it was a trend to remove both. I don't know if patients are thinking, well, I won't have to worry about it down the road, or it's going to provide more symmetry if I do both, when in fact we know that we can symmetrize by doing other methods other than just removing the breast. Am I making sense what I'm asking? And does that?
yeah, I think you make a very good and important point.
Mhm.
I think that for sure there are patients that they will not live. It's always, at least in my opinion, of a quality of life.
Yeah.
That's the center of everything, I think.
Mhm.
It's not like the best good looking or this or that. It's just, the quality of life that you can give to these
Mhm.
persons. And I think, it's many times when they are speaking about removing prophylactic the other side, there
Mhm.
are surgeons even not mentioning the feeling, the sensibility, or whatever, what it will change in their life, in their daily life. For sure, if we have a woman and she's just thinking every day, oh, I will have another breast cancer, I cannot survive the idea to go again in the chemotherapy period, and I have small children, and I just want to make as low as possible my risk of breast cancer. I understand that.
Yep.
That's no point about that.
Yeah.
And again, I don't think there is a decision that's good for everyone. We
Very
are,
true. Very true.
yeah, we are much more than that. And I try to speak really a lot with my patients, but it's at the end only a couple of hours. I don't know the whole life of someone. So there are many factors that have to be considered, because we don't have two breasts in front of us. We have a woman, and a part of this woman are the two breasts, but it's more complex. So I think it's important, but I think I always, for sure, with a genetic predisposition is another story.
Absolutely.
Okay, we live apart this category, of course, because it's logic. You reduce your risk so much.
Yep.
That is another story.
Mm-hmm.
But when you have breast cancer at one side, the question is, I think it has to be discussed with the patient,
Mm-hmm.
and has to be discussed like, okay, for sure, but you will be a different sensibility on the other side. So you will not, even if we can restore some sensibility, will not be what you have now.
Mm-hmm.
It's important for you to preserve the sensibility at the other side.
Mm.
What does it give in your quality of life? It's an important score moment or not? Because I think that at the end, fortunately, breast cancer can be cured in a lot of cases.
Yes.
Now, and that's fantastic. And I think that every woman want to go back to her life,
Mm-hmm.
and every woman want to forget what has been. And I think the only way to do that is to come as close as possible to a normal situation.
Yeah.
So for some women, it's really not important. They say, at least for what I see in my experience, remove the nipple areola complex, I don't mind. Or, oh, I've always had the dream to do a breast reduction. It can be very different, but I think it's an important point. I have some patients, very skinny, with a big breast, and I remember a couple of them, and it was so important for them to preserve the healthy breast, the shape, a ptotic breast, but the sensibility was very important. So we did like 2 or 3 flaps for one side, which is completely illogic for other women, but for them was so important. And so sometimes you push the boundaries to try to achieve the situation that can give the best quality of life to your patients.
Yeah.
So that's the first point. And so I think that the point, erogenous sensation, has to be openly spoken with your patient. Like, how is that important? It's important in your sexual life, in your daily life. It's important, the sensibility in your nipple areola complex. And then at least they have to be informed.
Mm-hmm.
But again, that's one aspect. And there is another aspect that I think has been underestimated for years, and is the concept of embodiment, and the sensibility of a breast seen as the feeling that you are complete and that your breast feels normal. And we can speak a lot about that, but this is a concept that is important for every single woman at this world, because it's not only important for the breast, but it's important for every part of our body. So let's try to explain that.
Yeah, this is what I wanted to touch on with you. I'm anxious to hear about this.
Yeah. And I think that this is also the reason why in the past it was not considered such a priority to give back sensibility, because everyone was focused on the erogenous sensation. That this is even more important. So, and you cannot ask that to patients, because if you don't have any experience on numbness, you don't know what does it mean. Because, for example, you don't think to your lips, you speak, you eat, you feel cold, you feel warm, and whatever, and you don't think you have a lip, and how happy you can be because you have a lip. But when you go to the dentist, and then it's numb because of, like an anesthesia. It
Mhm.
feels swollen. I think nearly everybody of us has experienced that once in life.
Yes.
And that's a bad sensation.
Yeah.
It's terrible. It doesn't feel normal, isn't it?
Mhm.
And this is something that's true for every single part of our body, because again, we are an organ to receive information from outside.
Mm.
And this concept of normality, it's very important. So we did this again, this study with interviewing healthy volunteers, and what it comes out is that the best situation for the breast, but it's the same for every part of the body, is the absent breast. So it's or the absent lip or the absent arm or the absent leg. So it's that part of your body that feels so normal and so comfortable that you don't think about that. So,
This resonates with me. I've mentioned this before in other podcasts, but after I had my mastectomy, because I had delayed deep, I was tripping because I was out of balance. And I couldn't figure out why. And I asked my breast surgeon, I said, why? And I didn't have large breast to begin with. But the absence of that, the removal of my breast totally threw off my balance. And she said, it's because you don't have that part of your body on you anymore. And now you're out of balance. That was one aspect, Dr. Tuinder. And then I talk to women so often, they talk about this internal itching or pain that they have. So yes, please continue. That just brought up those thoughts for me.
yeah, our brain is fantastic, but at the
Yeah.
same time, we don't know enough about that. And I think everyone has heard about phantom pain and phantom phenomenon for an arm or a leg, but nobody speaks about phantom phenomenon for a breast. So we did this study, with functional MRI. That means that we did a mapping on the somatosensory cortex to see which part of the brain is activated when you are touching a breast in healthy people.
Oh, what
And
did you find?
yes, because we have a very, a 7 Tesla fMRI, which is a very powerful MRI, functional MRI. And so we could map exactly the nipple-areolar complex and all the quadrant of a breast.
And which area of the brain is stimulated by that? By
Oh,
that touch?
the somatosensory cortex, which is the part of a brain, the superficial part of a brain, where there is, like, all the other parts of the body are also present.
Ah.
And some parts more than others. So
Mhm.
in the book, or you can just have a look on internet, there is this homunculus sensorius. So there is a man where with a big lips, big tongue, big hands, who represent this cortex, the somatosensory cortex, and is every part of the body is drawn dependently on the width of the brain cortex that is activated, touching
Mm.
that part. And for sure, the hands are very important.
Mhm.
The lips are very important. Funny enough, it was a man, so no breast.
Ah.
Historically. So it was a little bit forgotten part of our body there, but it's really, really present. And when we miss a part of our body, so what happens is that the nerves that were originally going to that part are cut. By definition, of course. I mean, you have to remove the tissue that it's not healthy. But all these nerves are just giving informations up the whole time because they are cut, that it's something wrong. That something wrong is in that part of the body, you know. And I always say to my patient, you know, if I say to you the whole day, you know, Terry, I think it's something wrong with you. I don't know, it's something wrong with you. It's something, you know, at the end of the day, you are thinking, oh, it's something wrong with me. Well, it's a stupid example, but to explain that I think it's important to explain that these messages are causing something here.
Yeah.
So it's not like someone is inventing things or whatever, but it's really happening something at brain level. And so, you know, we don't know a lot about the phantom phenomenon and the phantom pain that can also originate from that. But there are many women just missing their breast, like they will miss an hand or a leg, you know.
It's an amputation.
It's an amputation, exactly.
Yes.
Of course, it's also not true for everyone. There are some women that, and it's really what you said, it's really true. It's not dependent on the shape, on the volume, on whatever. We just don't know. But there are women that really don't feel complete anymore because of amputation.
You know, this is so self-affirming to me, that especially when you mentioned, Dr. Tuinder, that patients don't want to hear, well, I just think there's something wrong with you. You know, we know what we are and are not feeling. To verbalize it is another thing. But to have the conversation that we are having right now, if we could be having this in a consult, I hope patients are listening. I hope new fellows are listening. I hope other surgeons are listening. These are very affirming conversations to have, just to recognize, I know that you have a missing body part, and I know that there is a mind-body disconnection. We're trying to understand it and get there. So self-affirming, you said that.
Yeah, you know, I have sometimes, I don't know if it's in the same in the US. Of course, every country perhaps has also a different culture, you know, different background. But I really have sometimes women just coming to me and justifying that they want a reconstruction. So they are saying like, you know, yeah, I know I don't wear a very deep décolleté, but I think perhaps, and I say, you don't have to tell me. You have a missing part of your body. So if we can do something to restore it, it's perfect.
Yeah.
On the other way around, sometimes you have cases, and I remember a model coming from Belgium. So, you know, a nearly perfect body.
Yeah.
And I asked to her, I usually ask to my patient if they had already a mastectomy. I mean, otherwise it's another story, yeah, because fortunately, many times you can do a immediate reconstruction. But so this model had a mastectomy at one side. And I asked to her, you know, how much do you miss your breast? That's the question I always ask to my patients. How many times do you think that you miss a breast in a day? And she came to visit me, I think, 4 times, because everyone was pushing her to have a reconstruction.
Mm.
And she said, I never think to it. It's, I can wear my things, I can arrange. I said, well, then you don't have to have a reconstruction. It's also
Exactly.
fine.
Yeah.
Because you have a perfect body. Everything I'm doing, I'm just destroying another part of you. So, it's just an exception. The most women just miss their breast. That's what usually happen. But again, I think it's really, really important to listen to everyone. And just to try to understand, how can I improve your quality of life? What makes your life normal, and what can I do to achieve normality? Because I think more than perfection, most of the women wants just normality,
Yeah.
which is sometimes a different concept. And so that's the second point that I want to really to underline, because this is a point. You cannot ask to a woman in front of you who has at that moment two breasts, will you miss your breast? I mean, she cannot know. But for sure, perhaps it's not important, the erogenous sensation, but I am sure that at long term, the feeling that you can ask someone and not having the idea like a lip, try to give a kiss with your lip under anesthesia. It's not funny. So I think this is something important, and if it doesn't take too much work, or you are not sacrificing another part of your body, why not to do that?
Yeah.
And I can tell you that doing this sensate flaps, we just did it. We just finished, and we are analyzing the data about a double-blind randomized study. So it means that the patient doesn't know if she has a nerve or not, and
Mhm.
and the one doing the measurements also doesn't know if the patient has a nerve or not.
Okay, double blind. That makes, yep. Thanks for explaining that.
Yeah, because a lot of discussions in the past were also like, but it's biased, because you are saying to your patient that you are doing a nerve, so the patient will feel better afterwards. Well, I cannot say a lot because it's not yet published, but it's the interim analysis is published. So halfway we analyzed the data and they were positive. So if you have a nerve, you are feeling better.
Mhm.
The touch. And the data we are analyzing now are also very promising. That
Mhm.
is what I can say. So it worth it to do a nerve.
Yeah.
What I can say is that the sensation of cold and warm and pain are recovering less good.
Mm.
So it means that we have work to do to try to get closer to normality.
Mhm.
But for sure, with the techniques that we have in our hands, we can improve anyway the sensibility in the reconstructed breast.
Yeah, there's always so much surgical technique that I see and hear about at these conferences that really excites me. You know, going back to your comment about when you talk to a patient, it's so very personal about, you know, losing your breast, doing breast reconstruction, staying flat, whatever the choice is. But I think it's hard for patients to think about what the identity their breast had to them sometimes and the importance of it, because once you have been diagnosed with breast cancer, I speak from my personal experience, but this is a trend I also hear from other patients. It's like that part of my body is holding a disease. Get rid of it. I had what I would call a latent letdown or a latent realization my breasts were gone, because it was my second diagnosis. This is my story. Different story for everybody, as you know, Dr. Twinder. But I was determined. I'm like, I have to get rid of the cancer. But then a week after my double mastectomy, I had a complete emotional letdown when, I removed my bandages and it was gone. So it varies for everybody. I've heard of women who have had very large breasts and they wanted to remain flat because their breasts were burdensome to them throughout their life. It's so, so very personal. And like you said, listening to your patients and having the conversation is so important. I'm super happy to hear about these studies that are going on, though.
Yes.
Very, very important. Well, I feel like we can talk about this for quite a while and expand on this. I might be asking you for, you mentioned some of the bio, you mentioned a gentleman earlier, and I want to get that paper into the show notes so that people can look that up. Of course, papers that are not published yet, no, but you mentioned some others. So I want to get those in the show notes for the listeners. I can't thank you enough, especially since you are in the Netherlands. I'm speaking in the US. How is your communication? I know in the States, it's pretty, it's pretty clear how we all speak about this at conferences, and yet not everyone's talking about it. How is it in Europe when you're going country to country?
It's difficult. I think I think it's underestimated the importance,
Yeah.
and that's why I did a lot of studies, and I can give you of course the literature about that. But what I realize is that it's many times even don't mention to patients, and that's why I wanted to do this double-blind randomized study, because the thing is that many surgeons are thinking like, oh, it's not scientifically proven that it works, so I don't want to do that. So I needed to do something that was the basic science showing that it makes a difference.
Yeah.
Now we do a dual innervation, so we do 2 nerves instead of 1. We do a lot of playing around the techniques because, of course, as said, we are improving the results of sensibility, and you have to pay attention because the results are coming after the first differences between nerve and not nerve is after 1 year. But there is an improvement just lasting for 5-6 years. And we can see also that with a functional MRI, but let's say that apart. So I think we had to do this study just to show from a scientific point of view that there are techniques helping improving the sensibility. And so I hope will be published in a short time, the whole study. And showing good results. And we have to work on it to even having a better technique than what we have now. But again, also the fact to speak about the patient, with the patients about that, and choosing for the other side and all those kind of things, I think it's important. But it's not easy to. Again, a lot of surgeons are saying, "Well, I'm not sure about it. It's not working." And the other point is also that, you know, you have to have a long follow-up, a long-term follow-up to see the nerve working. So if you are seeing your patient after 3 months and after 6 months, and then you are not seeing your patient anymore, you don't see any results of your nerves.
Right. Because
So
generally speaking, isn't it about a year where you're getting?
it becomes to be a difference if you do a nerve or not. But there is improvement for 5-6 years after the reconstruction. So let's say you restore a little bit of sensibility or sensation is restored anyway, even if you don't do a nerve. So it's just worse, and then it just reaches a plateau. But with a nerve, it's going up, going up, going up, and just try to go up, go up. So you have to wait a lot to see a difference.
Yeah.
That's the point.
Yes.
And it seems that it's worth it, even if you are sparing the skin and the nipple areola complex of the patient. So you can improve sensation if you do a nerve coaptation and so on.
Yeah.
But I think that the most important thing is that patient have to be informed, and it's for sure lacking in Europe.
I feel the same way. I get the same thing over in the US. I really feel, Dr. Twinder, and why I'm so appreciative you've done this today. I think that it's going to take patients knowing to ask about this and surgeons willing to try, willing to add it to their armamentarium. And if patients drive this, if they ask the question and they say it's important to surgeons, hopefully we will see that go up and up and up.
Yes, I'm sure about that.
Yeah. Well, thank you so much for joining me today. I am so appreciative. You look lovely and refreshed. I just caught you off of holiday. I know you're going to be back at work and going to London Breast again this year. So all the best to you. I hope to see you again soon. And if not, thank you so much for joining me today and getting this important information out. It's delightful, informative, and I appreciate you.
Yeah, thank you so much. And for sure, I am available for all the patients, and for everybody needs more information about that. What I can do with all my heart.
Oh, thank you. That is a great way to end it, with all my heart. Thank you so much, Dr. Tuinder.
Okay. Have a
Bye-bye.
nice day.
Uh-huh.
Bye.